Today, he was transferred to your unit. As you assess his cardiac rhythm, you notice a normal sinus rhythm with occasional PVCs. Suddenly, Mr. Masterson reports palpitations and lightheadedness. When you obtain an ECG tracing, you identify episodes of ventricular tachycardia, which the physician confirms. To treat this arrhythmia, you know you must administer the right drugs quickly to prevent myocardial injury from worsening. But first, recall how ventricular tachycardia commonly results from an MI. After an MI, the adrenal glands release more catecholamines than normal, which stimulates the myocardium to pump harder and faster. This catecholamine surge increases myocardial cell automaticity and can cause irritable cells in the injured ventricle to fire rapidly and out of sync with healthy myocardial cells. Ventricular tachycardia also can occur when injured myocardial tissue conducts impulses slower than nearby healthy tissue, creating two pathways, a fast one and a slow one. Impulses travel normally down the fast pathway. They also travel down the slow pathway, delaying conduction long enough for the fast pathway to repolarize, and for the delayed impulse to travel up the fast pathway and back down the slow pathway. This creates a continuous re-entry circuit that leads to ventricular tachycardia. To break this re-entry circuit, immediate drug therapy calls for a Class 1B antiarrhythmic, such as lidocane, a Class 1A antiarrhythmic, such as procainamide, or a Class 3 antiarrhythmic, such as amiodarone. Before treating your patient's ventricular tachycardia, make sure he has a pulse and is conscious. If he has no pulse, is unconscious, or shows other signs of cardiac instability, prepare for immediate cardioversion. Also ensure that the patient's ventricular rate falls between 150 and 250 beats per minute. A slower rate may signal an accelerated idioventricular rhythm, which requires different drug therapy. Then, as prescribed, administer a Class 1B antiarrhythmic, such as lidocane, by IV bolus. To do this, give a loading dose of 50 to 100 milligrams. If needed, repeat this dose in 5 to 10 minutes. If lidocaine corrects the arrhythmia, start a maintenance dosage of 1 to 4 milligrams per minute, as prescribed. And because lidocaine has a short half-life, maintain this continuous infusion without interruption. However, if ventricular tachycardia recurs during the infusion, expect to administer another lidocaine bolus and increase the infusion rate as prescribed. In the ventricles, lidocaine blocks sodium channels in myocardial cell membranes, which prevents sodium from entering the cells. This action reduces automaticity and cell depolarization in ventricular cells. Lidocaine also stabilizes cell membranes, which can reduce the cell's responsiveness to impulses. During lidocaine treatment, check for a therapeutic drug level, which ranges from 1.5 to 5 micrograms per milliliter. If the level exceeds 5 micrograms per milliliter, watch for drowsiness, confusion, and other adverse reactions in the central nervous system. If lidocaine doesn't correct the patient's ventricular tachycardia, the physician may prescribe a Class 1A antiarrhythmic, such as procainamide. But keep in mind that procainamide shouldn't be given to a patient who's receiving a butylide, because their interaction may produce fatal arrhythmias. Intravenously inject procainamide 100 milligrams diluted in 5% dextrose in water every 5 minutes at a rate not to exceed 50 milligrams per minute to a total of 500 milligrams. Alternatively, infuse a loading dose of 500 to 600 milligrams diluted in 5% dextrose in water continuously over 20 to 25 minutes at a rate not to exceed 50 milligrams per minute. Then administer the maintenance dosage, giving 2 to 6 milligrams per minute by continuous infusion. Procainamide reduces the formation and conduction of ectopic impulses in the ventricles, and its metabolite, NAPA, increases the refractory period in myocardial cells, prolonging the time between cell stimulation and restimulation. During procainamide therapy, monitor the patient's procainamide and NAPA levels regularly. Check for therapeutic levels, which are 4 to 10 milligrams of procainamide per liter and 10 to 30 milligrams of NAPA per liter. Higher levels can lead to torsade de pointe and other adverse reactions. Lower levels may not control the arrhythmia. During procainamide therapy, assess for drug effectiveness and adverse reactions, such as torsade de pointe. This dangerous multifocal ventricular tachycardia is characterized by wide erratic QRS complexes that fall above and below the isoelectric line. Torsade de pointe can occur if procainamide or other drug prolongs the repolarization period, represented by the end of the QT interval. Then, if another impulse tries to stimulate the cell during this period, it causes triggered activity. This activity occurs when the cell fires several times and triggers ectopic sites in the ventricles to fire too. To manage torsade de pointe, stop the infusion and begin advanced cardiac life support. Then expect to use an emergency external pacemaker or electrical cardioversion if needed. Or plan to administer the beta agonist isoproterenol. If prescribed, infuse 2 micrograms per minute and slowly increase the dose until torsade de pointe resolves. By stimulating beta-1 receptors in the heart, isoproterenol stimulates SA node automaticity, which raises the heart rate. By raising the heart rate, the drug reduces repolarization time and shortens the QT interval, which suppresses torsade de pointe. However, isoproterenol also stimulates beta-2 receptors in vascular smooth muscles, and this may cause peripheral vasodilation and hypotension. During isoproterenol therapy, assess for signs of worsening myocardial ischemia, such as ECG changes and chest pain. That's because stimulation of beta-1 receptors can increase myocardial contractility, which increases myocardial oxygen demand and can worsen ischemia. If isoproterenol doesn't effectively treat torsade de pointe, the physician may order magnesium sulfate. Intravenously administer 1 to 2 grams diluted in 100 milliliters of 5% dextrose and water over 1 to 2 minutes. Then add 1 to 2 grams of magnesium to 250 milliliters of 5% dextrose and water or normal saline.